Hello, I'm Paul Campbell. I work as the clinical lead for Northwest Boroughs IAPT services and also as the clinical lead for adult IAPT for the Greater Manchester and Eastern Cheshire Strategic Clinical Network. So I've been asked today to come along and talk a bit about how we treat PTSD, specifically in primary care. And lots of people, I won't need to explain what IAPT is to anyone. We all know that it's the main venue in which primary care psychological therapies are delivered. What people mightn't know is that it actually came from a terrorist event. It was the kickstart for IAPT. Shortly after the Omagh bombing that Alan mentioned, there was a request went to the Oxford Trauma Centre to improve access to psychological therapies for those affected by the bomb. And it showed two things: that you can deliver psychological therapies en masse and quite quickly to people, and also that you can measure sessionally the outcome. So those are the two main things that come out of that. Was it's possible to very quickly and with resource to increase access to psychological therapies, and for that to be proven to be clinically effective and demonstrated to be effective. So that was the first. That was the first. The embryonic phase of IAPT was that we realised that you can measure sessionally and that you can demonstrate that interventions work. And then subsequently things like Lord Layard's report came along to provide the financial backing for that. So I'll talk a bit about the way we treat IAPT in primary care. And the first thing I want to think about is whether or not how we treat PTSD, whether or not we're actually identifying PTSD when it comes along. We know that most people who come to an IAPT service get a problem descriptor, or what used to be called a provisional diagnosis. And what we know from the data is that most people who receive that provisional diagnosis, it's usually either depression, generalised anxiety disorder, or mixed anxiety and depression. And the default used to be that clinicians would say, well, they use the PHQ, and if they're depressed, then that's depression. They use the GAD, and it's a measure of generalised anxiety disorder. So if they score in that, they've got generalised anxiety disorder. And if it's a bit of both, we'll call it mixed anxiety and depression. So a lot of work has gone on over the past year or two to get people to diagnose more, describe the problem more, and also to put some more thought into how we're doing it. I need to thank David Clark and the national team who gave us some data on this. So this was a piece of work they did in 2016, and it looks at the percentages of the different disorders that were diagnosed by PWPs when people first presented to IAPT services. And usually in a lot of IAPT services, the first appointment is a very, very brief one. Quite often it's over the phone, and it's quite often carried out by PWPs. And there isn't the space to do a proper exploration of people's difficulties. It's usually, are you in the right place and are you risky? And can you go onto our books? So this is in no way to denigrate the skills of PWPs in their diagnosis. But what they did was they took a cohort of patients who were assessed by PWPs in this brief triage in an IAPT service, and then they gave these clients the psychiatric disorder screening questionnaires. And I'll draw your attention to PTSD down here. What they found was 1% of the people in their cohort who presented were diagnosed with PTSD by PWP, but when they applied the proper and took time to apply the proper psychiatric screening tool, it was 40% of those people should have had a diagnosis of PTSD. So as I say, that's not the PWP's fault, that's the system's fault. And it's not only in IAPT that we see these things. So this is some data from the Adult Psychiatric Morbidity Survey that was published last year. And along the top here is the diagnosis that people would have received in receiving a proper diagnostic assessment. Because the clinical interview schedule revised. And down here is, have you ever been diagnosed with these disorders in primary care? Well, it says here by a professional, but in that read GP. We're looking at the GP diagnoses here. And so what we can see from this, so for example, if we look at OCD, those people who had OCD, who were identified as having OCD with a proper clinical assessment, 83% of those in primary care received a diagnosis of depression. Only 13.2% of them actually have ever received a diagnosis of OCD. Same with phobias. Of those people, the 100% of people who have phobias, only 7.2% of them ever received a diagnosis of that. Again, they were diagnosed with depression. So it seems that in primary care we're very good at seeing depression even when it's not there. This is probably the least scientific slide you will ever see in any presentation at the PPN annual conference. This is just me looking at 3 services, looking at the proportion of their high intensity staff who were trained in both CBT and EMDR, and looking at and comparing it with the proportion of expected PTSD diagnoses. So for these 3 services, their prevalence rate for PTSD, we should expect to see about 10% of their caseloads to be PTSD in these, based on the Adult Psychiatric Morbidity Survey. So the green one is the percentage of HITs who were also trained in EMDR. And I'll draw your attention to these last 2, and basically to say that there are twice as many people in Service 2 trained in EMDR and twice as many people diagnosed with PTSD in that service compared to Service 3. You would expect all these services to have diagnosed PTSD up around the 10% level. So it's completely unscientific, but it does flag the issue of EMDR up to us. That it doesn't seem to be from this that people who are trained in EMDR are overinflating the diagnosis of PTSD, because you would expect 10% in that service. It's that they're better at recognising it than those who aren't trained in EMDR. And it's some people criticise it and say, well, if you have a screwdriver, all you see is screws and you don't see nails anywhere. Remember that there should be 10% of these populations diagnosed with PTSD. So, are we identifying it? No, we're not really. We need to get better at identifying. And that's one of the things that's come out of the national work on improving recovery rates, is that those services who are better at identifying disorders tend to be better at treating them. So, thinking about how well IAPT does in the treatment of PTSD. And I've outlined here a very typical IAPT pathway of old. This is one that's been in use, probably still in use in a lot of services, but was the general way to treat people in IAPT services. So I won't go through it in detail. I want to focus on PTSD. But down the bottom we've got primary care step 1, so GP, that watchful waiting we were talking about, and we'll talk a bit more about that in a minute. Step 2 was things like generalised anxiety, depression, panic, those types of low-level anxiety disorders. A wee bit of OCD, mild to moderate OCD would be treated in step 2. And then you'd only really start to see PTSD presentations in step 3. So that's your typical, and I copied and pasted this off, I won't name the service, but I Googled IAPT step care pathway, and this came up from one of the services. And it's very typical of lots of services. This is guidance that came out, the NICE guidance in 2011 that came out, and we know that most IAPT services put people, actually don't do step care, they do stratified care, and they send people with PTSD straight to step 3 for their interventions, where they'll probably wait a wee bit longer but get something a bit more intensive. But this NICE guidance says is actually you can start treating PTSD at step 2. You mightn't necessarily be doing complete trauma-focused work or complete EMDR protocols, but you can start that psychotherapeutic, psychological therapeutic and individual guided self-help type work at step 2 with people with PTSD. So what we've noticed over the last year or so is services are starting to move to that. So the services that I work with, we now put people with PTSD, everybody goes through step 2. So thinking about how well IAPT services nationally do with PTSD, and again, it's not very well. So these are the recovery rates by disorder. So thing we're best at treating is specific phobias. We're very good at treating GAD, and if you remember, we're very good at identifying GAD as well and diagnosing people with GAD. So around 50% is the national recovery rate target, around 51% is the national average with regards to recovery rate generally. And we see down here that PTSD, 37.5% of people recover after a treatment of PTSD. That might sound good in the trials, a third get better, a third don't change and a third get worse. It's actually on a par with the lowest recovery rates in the country. So if you look at all the recovery rates of every service, the bottom 5 or 10 are in the mid to low 30s recovery rate wise. So we're not doing very well PTSD wise. So some of the reasons for this might be waiting times. If you think lots of services send people to step 3 where the wait is a bit longer than for step 2. And what this shows is reliable improvement after therapy and the amount of weeks you've waited for your therapy. And you can see there's a virtual cliff at 6 weeks. So what it basically, when these access standards come in that everybody should start treatment within 6 weeks, that wasn't an arbitrary figure, that was based on these figures that we found was if you start your treatment within 6 weeks, your reliable improvement, which is a significant improvement on the scales, is more likely to happen. If you wait 50 days, 75 days, you're very unlikely to move any significant amount on the scales. So that might be one thing. People with PTSD are waiting longer because they have to wait for step 3, for example. Also, this looks at reliable improvement and number of sessions. And there's a sweet spot here around nine sessions. And what we find is that's around the national average for the amount of sessions. So all these dots are services around the country. So we see that they're sort of clustered around here. So we're giving people enough sessions to recover from PTSD. This doesn't break it down by step, so we don't know what's going on there. So we're giving people enough of the treatment, we just might be giving it to them quickly enough, or might be giving them the right treatment. So what could we do better? Firstly, recognising PTSD when it comes along, not calling it something else. Starting the treatment within 6 weeks so we don't get that cliff effect. Handle the first 4 weeks better, and I'll come back to that in a minute. We've touched on the EMDR, better recognition of EMDR. And this thing, out of clinic visits, IAPT services and therapists in IAPT services really don't feel like they can do stuff like this, that they can't bring a client to the site of their trauma because there's so much else to do and they fit 6 people into their day and 6 1-hour appointments in a day and they can't do these types of things. But services really need to start valuing this more if we're going to successfully treat PTSD and bring them up from the lowest recovery rates in the country to the average. So thinking about what we can learn from the Manchester event. I won't go over again what everybody said about services putting together, but it really was it was the morning after the attack that we had our first teleconference and things started rolling out there. And lots of services and lots of people contributed to our response. And one of the things that we came up with was guidance for professionals. And we used the Thrive model that Claire mentioned in children's services, simply so that we had the same message. Also, it gave a nice non-clinical and sort of non-emergency response type ethos to it. So I'll briefly go through these. So we broke it down into a few different phases. So you'll notice here that this preventative stuff is we basically wanted to give people advice on what to do when somebody presents with possible trauma symptoms related to the event. And that was simply encourage people to talk about it if they want to. Don't force them to talk about it, but encourage them to talk about it. Make support available, make space available, make social networks available for them. It would be lovely if we had a centre where people gather. Sometimes when these incidents happen, there's a place where people can gather together. But as we've heard today, people were dispersed all over the country. And we couldn't really have a geographical place. So we wanted the same message to go out. Next, we have what's been described as watchful waiting so far today. And the message we wanted to get over here is that the one thing watchful waiting is do nothing. It's not send somebody off to wait on their symptoms getting worse. And sometimes that's the way it's been translated, certainly by GPs and by psychological practitioners, that it's the first 4 weeks you shouldn't offer them anything. First 4 weeks, if people are distressed, the message should be, it's very understandable that you're distressed. If you want some help managing that distress, then let's give you some help managing that distress. We should be helping people to manage their distress, and finding that balance between not giving them nothing and telling them they're not allowed to talk about this because it might be damaging to them, and not rushing in and giving them intensive therapy in those first 4 weeks. So that was our view of watchful waiting, and we wanted to get that message out there, that it's not send people away with nothing, but it's not call in the helicopters and start their in-depth therapy right away. Then we put some advice in about treating not only PTSD, but those who have aren't presenting with PTSD symptoms, but might be depressed as a result of this, or might be anxious as a result of this. And then some stuff on what to do when people get risky. So we wanted to offer something to the community, and that clients can use and say, this says you should be offering me this, can you tell me where to get it? And there's lots of stuff in there, lots of resources, links to resources that people can use. So the things we learned from the Manchester attack that we might apply generally to services are joined up working. Joined up working works. It worked before competitive tendering, and it worked after the Manchester arena, so it can work. The difficulty is that sometimes Step 2 and Step 3 in an IAPT service are provided by different companies and different organisations, and sometimes there's not even that joined up working within a service. Early normalisation is good, but that needs to come with better support for GPs and people like that, so that people don't understand it as waiting until the real problem comes along. It's about helping them manage their distress while they're waiting. The other thing we learned is only provide evidence-based therapies. We've touched on that a few times. There were lots of offers that were great, lots of offers that didn't have much of an evidence base around them. And the other thing we found was effective clinical leadership. So our role in a lot of this was about helping clinicians to do what they do every day, rather than tell them to do things different. It's about providing that leadership and support and that guidance behind people. So that's all I have to say on PTSD and primary care. So the take-home message is we're not very good at identifying it, we're not very good at treating it at the minute, but there's lots and lots we can do to improve that. Thank you.